So it's my honor to introduce the second speaker, Professor Tony Kelleher from Australia. He is a Scientia professor in the University of New South Wales, Australia. Tony is an immunologist, especially in immunovirology. He is the director of the Kirby Institute after David Cooper, whom we know well. And Tony is was the past dean of the medical school in University of New South Wales. So it's very appropriate for him to give a talk today on update on long COVID. Tony, please.
Thank you, Prapan. It's a great honor to be here, and it's even a greater honor to follow KIAT, and I hope to keep up the extraordinary standard. I think you've just seen a presentation of truly world-class data from KIAT, and I'd like to congratulate him on his extraordinary efforts in the field. So I wanted to give, I was asked to give an update on insights into long COVID. These are my conflicts of interest, none of which impact on what I'm going to present today. So long COVID is the prolonged symptomatology following the acute infection with SARS-CoV-2. Part of the problem with studying long COVID is there are multiple definitions, and those definitions both relate to how we define chronicity. When does long COVID start? Some people say as soon as 4 weeks post-acute infection, others say out to 4 months. And then there's a huge constellation of symptoms that have been associated with long COVID. Literally over hundreds of symptoms have been associated, and they fall into about 5 categories. Constitutional symptoms such as fatigue, malaise, these are particularly post-exercise, and decreased exercise capacity. Respiratory symptoms such as breathlessness, perceived shortness of breath and chest pain. Musculoskeletal symptoms such as myalgia and arthralgias. Neurological symptoms such as brain fog, difficulties with mentation, confusion, and then autonomic type symptoms such as POTS. And then a range of gastrointestinal symptoms such as nausea, vomiting, diarrhea, abdominal pain, and anorexia. I think when we're talking about long COVID, we need to be very careful about distinguishing the complications of severe acute COVID, such as ARDS, myocardial disease, or the complications of thromboembolic phenomenon that occur during the acute phase of the illness or result from admission to ICU from and recovery or the damage that is caused by acute COVID against the symptoms that are associated with this phenomenon called long COVID. There is a history of post-viral fatigue syndromes. These were described as early as the 1890s after the outbreak of flu, and then a similar description was found after the outbreak of the 1918 flu. It's also well described after viral illnesses such as EBV, and it's also been described after SARS-CoV-1. One of the questions is how much does this overlap with phenomena such as chronic fatigue syndrome or ME? And I think one of the other questions we need to keep asking ourselves is what triggers this syndrome the same or different than what maintains this syndrome and its symptoms? It certainly appears to occur less frequently if the infection is treated with antivirals during the acute infection. If the infection occurs after someone has been vaccinated, the prevalence of this is less common. And it appears to be less common with the newer variants that have a tropism for the upper rather than the lower respiratory tree. I think it's very important, if we can, to understand the pathophysiology of this illness so we can develop rational approaches to treatment rather than the empiric approaches that we're taking at the moment. So I think, in short, the pathophysiology of this condition is very poorly understood. There are a range of proposed mechanisms that I list here, and I'm going to go into some of these in more detail throughout the talk. But the main proposed mechanisms relate to aberrant or persistent immune responses, both in the innate and in adaptive immune systems. And contained within that, is there a role for the generation of autoantibodies during acute COVID infection that then precipitate long COVID? Is there persistence of antigen or viral RNA? And does that occur in reservoirs, and does that drive the chronicity of this illness? Is there some sort of initial damage that then triggers damage and repair cycles in epithelial and endothelial surfaces that precipitate the symptoms? Is there direct infection of neurological tissues? And is there ongoing thrombotic or embolic phenomena, including the presence of microclots in circulation? So most of the studies on long COVID have been, at least the pathophysiological studies, have been cohort studies, and these are often small. They're often limited to less than a year's follow-up, and they're often the most studied time points, often very shortly after the acute infection at 3 to 4 months. And I'm going to show you some data later to show you why I think that's not ideal. I think those points have to be included, but making conclusions from responses at 3 to 4 months, I think, is fraud. And a lot of these studies are cross-sectional, and almost none have any validation cohorts. There was a long COVID conference put together by Keystone in the second half of last year, which brought together a range of stakeholders, both scientists, funders, clinicians, and the community. And I'm going to summarize some of the main findings from that, what I thought was a really great conference, because I think it provides really up-to-date information about the mechanisms or the potential mechanisms and where we understand the pathophysiology of this disease, this syndrome is up to. So in terms of the idea, is there antigen persistence or viral persistence? So there is evidence, particularly from the Henrik and Peluso groups with Steve Deeks in California, that there is persistence of antigen in the serum, and there is persistence in some people of viral RNA in the gastrointestinal tree, particularly from sigmoid biopsies. However, there is persistence of antigen found both in people with and without long COVID. Not everybody that has long COVID has persistent antigen or RNA detected, and those things can be detected in people that have been fully recovered. So although it may be playing a role in the pathogenesis, it's not the full story. Where the RNA is detected in the intestinal biopsies, this is associated with an inflammatory process that is associated with an accumulation of macrophages in the tissues, suggesting a nidus of ongoing inflammation. So this is early days with this. Certainly no one, I think, has demonstrated ongoing viral replication. So whether this is persistent of antigen and RNA in the presence of things like monocytoid dendritic cells, where we know antigen such as HIV can persist for many, many years in tissue, I think is still trying to be understood. The same group has got some very interesting data about reactivation of herpes viruses. This seems to be associated with reactivation of EBV rather than CMV, but also possibly reactivation of other retroviral elements. But again, that hypothesis, the data supporting that hypothesis is still early and preliminary. There is some evidence for the idea of exuberant epithelial repair. There seems to be, particularly in BAL samples, some evidence from the lung of overdrive of epithelial stem cells, particularly driven by activation of MAP kinase 13. Again, this is where the overlap with ongoing damage and people recovering from ARDS gets a little difficult in terms of how these populations have been put together, but certainly intervening by inhibiting MAP kinase 13 may be a way of preventing ongoing lung fibrosis. There is, from one group, I think quite elegant data, and the group is from South Africa, but is reproducing that data in cohorts from the United States of microclots and platelet activation and ongoing endothelial dysfunction in people with long COVID. But again, how that associates with the disease and what's triggering it is unclear. There is, again, from small cohort studies, very good evidence, I think, of in certain people of autonomic dysfunction in a subset of patients. And this autonomic dysfunction seems to have significant outcomes in that it results in during exercise, results in poor venous return to the right atrium due to lack of venoconstriction, and therefore a limit in cardiac output in being able to respond to exercise. And there is at the same time in those same people evidence of a peripheral left to right shunt and a lack of use of oxygen in the periphery. Interestingly, at the same conference, a Dutch group showed that there were changes in muscle pathology after exercise in people with long COVID, with a loss of type 1 myocytes and an increase in type 2 glycolytic myocytes, and a loss of mitochondrial function within the muscles. And also amyloid deposition. So that lack of mitochondrial function may explain some of the left to right shunt that the others have seen due to the lack of oxygen. The amyloid deposition is interesting in that it's not in the capillaries. It doesn't seem to be associated with ischemia, so it doesn't relate directly back to the microclot hypothesis, but seems to be in the damaged muscles directly. And then a number of groups have shown that exercise in a subgroup of people is associated with significant reductions in VO2 max, and I'm talking about a third to a half reduction in VO2 max, which is very significant and reproducible. There are others that have shown that there is lipid dysregulation, particularly in adipocyte function and increase changes in HDL metabolism. And there's also inflammation, again, of macrophages into adipose tissue and evidence of inflammation within the adipose tissue, but no yet demonstration of antigen within that tissue. Dr. Iwasaki, who's done a lot of research in this area, has shown that there are reduced levels of steroid hormones in general in people with long COVID, and in particular sex hormones. And so severity in her cohorts, cross-sectional cohorts, seem to relate to reduced cortisol levels and reduced testosterone in females and reduced estrogen in males. And I think that those observations need validation, but are extremely interesting in terms of an adreno-hypopituitary axis dysregulation. The NIH has shown that there's no direct infection of neural tissues, at least in autopsy samples, but has shown that there is indirect evidence for activation of microglia and perivascular macrophage activation. So I wanted to change gear a little bit and give you some more detailed information about a study that we've conducted in Sydney called ADAPT. And ADAPT was set up as a study to study convalescence and particularly immune convalescence, with the idea of identifying donors that had the most appropriate phenotype for production of hyperimmune globulin. The first cohort that I'm going to describe here recruited 100 PCR positive patients who were identified at community testing sites on the basis of a multiplexed PCR, and they were recruited at the time of testing. And we commenced this in April, May 2020, and we followed these patients out prospectively for 2 years. All of these were with infections with the ancestral or alpha strain, all pre-Delta. 90% were managed in the community, only 10% were hospitalised, and only 2% ended up in ICU. So really a community-based cohort. And to be included as, and in the initial description of long COVID in Australia, approximately a third of this 100 people had symptoms consisting of fatigue, dyspnea, and chest tightness at 80 days post the initial infection. And the predictive factors for that were severity of the acute illness and female sex. So we took those 31 patients who we defined as having at least greater than one persistent symptom of dyspnea, chest pain or tightness, fatigue or malaise for greater than 90 days after the initial infection and labelled them long COVID. And in the subsequent slides, those patients will all be shown in red. And then we, from that same cohort, we sex and age matched those with people that had fully recovered. We also, because we'd had multiplex PCRs done, we were able to recruit 25 patients who, at the time of presenting for screening for SARS-CoV-2, were diagnosed with a prevalent coronavirus. And we followed those people with the same protocol. And then we also had 16 healthy controls who had been recruited to another study in early 2019, well prior to the COVID epidemic. And these were examined at 3, 4, 8, 12, and 24 months after diagnosis. And just to remind you, this is an early cohort. There were no vaccines available, so none of these were vaccinated. And they were all infected with early strains. So all the data needs to be interpreted in that light. So these were all primary infections. This is the time course. We did cellular serum and serum analytes and serum antibody assays at 3, 8, and 24 months. And we, in both groups, to the same schedule. And those groups at 3 to 4 months, 8 months, 12, and 24 months had standardized health-related quality of life and impacts of daily activities assessed at each visit by a standardized questionnaire. By the end of the study, 85% of the cohort were fully vaccinated, and this occurred between 12 and 24 months. And this is consistent with the overall uptake of vaccines in Australia. The first vaccine was received at a median of 16 months post the first infection, and there was no difference in vaccine uptake between the matched controls and the long COVID patients. And in both groups, 8 patients were reinfected during the period of observation at a median of 22 months post-infection. And as I'm going to be showing you a lot of immunological data, it's important to remember those things occur and complicate the interpretation of the data. So the first thing to note is there was no difference in viral load between these two groups during the acute phase of the illness at diagnosis. And neutralization titers were higher in the long COVID group compared to the matched controls. Again, long COVID in red, matched controls in blue, at the early time points at 3, 4, and 8 months, but not at 12 months. And both had much higher levels of neutralizing antibodies and a live virus neutralization assay at 24 months, which is probably the result of both vaccination and or reinfection. And in these graphs, the patients who have been reinfected are shown as black dots. So you can see the effect of reinfection in those patients. And you can see that those people that had recent reinfection had higher levels, as expected, of nuclear capsid antibodies, confirming that recent diagnosis just prior to 24 months. So a higher level of antibodies at the early time points, but apparent resolution over time. Similarly, higher levels of both CD4 and CD8 T cells, at the early time points, 3 and 8 months, but not at 24 months to both spike and to nuclear capsid. And so early immune activation, early strong responses, stronger in the long COVID than in the matched controls, but apparent resolution by 24 months in the CD4 cells, but not so in the CD8 T cells, though the levels were reducing again in the long COVID patients. On those CD8 T cells at the early time points, there were higher levels of activation or exhaustion markers such as PD-1 and TIM-3, but these again had resolved and no difference between the two groups at the 24-month time point. We looked at 30 different serum analytes in serum. I won't list them all here, but at 4 months we noticed 6 cytokines, interferon beta, interferon lambda, MIG-1, IP-10, IL-8 and soluble TIM-3 that were higher in the long COVID patients, but also higher in the matched controls than in that group that were infected with the prevalent coronaviruses. So in everybody who had been exposed to this virus for the first time, at 4 months, they still had significant activation of their immune system as judged by the expression of those 6 cytokines. By 8 months, the levels of interferon beta and interferon lambda, a type 3 interferon, was higher in the long COVIDs, was still raised in the long COVIDs, but had resolved in the matched controls. And in all those other cytokines that were raised at 4 months, those levels had returned to normal levels, no different from the healthy controls by 8 months. So there was this residual activation of interferon beta, a type 1 interferon, and interferon lambda, a type 3 interferon at 8 months in the long COVID, but not the matched controls. When we took those 30 analytes and did a log linear machine learning analysis at the 8-month time point, we found that the 4 analytes, interferon beta, pentraxin 3, which is a TNF inducible protein, IL-6, which is, as you know, an acute phase reactant, and interferon lambda, a type 3 interferon, predicted those with long COVID with about an 80% accuracy. When we looked at the 24-month time points, of those 6 analytes, there were no differences between the two groups except for interferon gamma, which appeared to be driven by those people who had had reinfection, and a persistent increase in interferon beta. When we took those with reinfection out of the analysis, we showed that these differences were no longer significant. So again, apparent resolution of the immune drivers by 24 months. In terms of the looking further at the innate immune system and where these cytokines might be coming from, we noticed increases again at these early time points at 3 and 8 months in activation status of both monocytes and plasmacytoid, but not monocytoid dendritic cells at 3 and 8 months in the long COVIDs, but not in the matched controls, and these again had resolved by the 24-month time point. And remember, plasmacytoid dendritic cells are a very good source of type 1 interferons, and monocytes are a good source of type 3 interferons in epithelial surfaces. And also go with that observation of activation of macrophages within tissues. When we looked at a range of single cell profiling, we detected dysregulation within lymphocyte subsets in the long COVID patients compared to the matched controls. And this was particularly at 4 and 8 months. There were depletion of a certain subset, of a resting subset of naive T and B cells, and in the T cells it was both within the CD4 and CD8 populations, and then a loss of other certain effector CD8 T cell populations. At 8 months, those effector cell populations had begun to repopulate, but there was no reconstitution of the naive T or B cell subsets. However, by 24 months, by single cell profiling, those differences between naive B cells, naive CD4 cells, and naive CD8 T cells between the match controls and long COVIDs were no longer detectable, and there were no differences across a range of T cell memory and effector subsets, T regulatory subsets, cytotoxic T cells, various innate immune cells, B cells, monocytes and plasmacytoid dendritic cells. There was no difference in the single cell transcriptomics at 24 months between those two groups in terms of the distribution of those populations. There was, by single cell profiling, some residual evidence of interferon stimulation of CD14 monocytes, but not of any other innate cell population. And there was no difference in the exhaustion scores, that is the expression of transcripts for activation markers in either CD4 or CD8 T cells across a range of subsets, including central memory and effector memory, naive and cytotoxic T cells. So as I said, we did a range of quality of life scores at intervals, and the data for, sorry, this is jumping around. The data is shown here at 4, 12, and 24 months for the match controls and long COVIDs. Essentially, the higher the score, the more normal your quality of life score is, and you can see that the matched controls had higher quality of life scores than the long COVIDs. In general, there was improvement across the board, but there were people in the long COVID group who got worse during that time. And when we applied statistics to this, there was a clear difference in the quality of life scores by the EQ5D between the matched controls and the long COVID shown here, but this had resolved by 24 months. When we looked at the functional status assessed, we found that these lagged behind the quality of life scores, and so there was a residual of people who who still felt that they had not returned to their pre-COVID work levels, that had not returned to their usual activities of daily living, and had not returned to their normal exercise level. So while there was significant recovery, there were significant numbers of people, about 20%, who were still suffering the symptoms of long COVID at 24 months. So we looked for what the correlates of this recovery were using 15 blood parameters that we thought might be relatively easily measured in a clinical laboratory, and these are listed here and include things like cholesterol, blood sugar level, neutrophil and lymphocyte counts, as well as a range of cytokines that we had seen were raised, CRP, D-dimer, platelets and troponin. And we looked for associations between these and improved quality of life scores. And we found, again, using a machine learning approach, that we could distinguish using pentraxin-3 platelets and CRP with an accuracy of about 70%. We could distinguish those that were likely to recover versus those that were unlikely to recover. While this is very encouraging, the problem is that each of these measures, or the majority of these measures, were actually within the normal range, and so we were looking at variation within the normal range. So for a clinician sitting with a patient looking at these results, they would be impossible to interpret. So I don't think there's a great deal of clinical utility to that approach, at least with the analytes that we've looked at so far. So in summary, I hope I've shown you that at 8 months in those with long COVID, there is a diffuse immune dysregulation that's associated with activation of the innate immune system, particularly shown by higher levels of type 1 and type 3 interferons, increased activation of plasmacytoid dendritic cells and monocytes, and then depletion of certain subsets of T cells, particularly naive CD4 and CD8, as well as B cells, and increased expression of memory T cells. This may be an issue of activation of the innate immune system driving bystander activation of the adaptive immune system, or it may be driven by potential antigen presentation. We're trying to dissect that. These abnormalities tend to resolve over by month 24. So I think we're starting to both show the natural history of this disease, both clinically and biologically, that there is a trend towards resolution. But we haven't uncovered the correlate of that likelihood for recovery. As I said, the quality of life increases over time in most but not all, and some of the functional measures of capacity lag behind that improvement in quality of life. So far, we've got limited clinical utility for suites of parameters that are associated with recovery. This data, as I said, relates to people with primary infection, pre-vaccination with the early strains of the disease. We're currently looking at similar cohorts that were infected with Delta and Omicron, and those results are ongoing in the lab. And we are also looking in those populations at people post-vaccination to see if there is modulation of that innate immune response. That innate immune response may persist because this is a primary infection. It's the first time you've seen the antigen. And in people that have been previously vaccinated, then the immune profile may look quite different because of the primed adaptive immune response. And we're trying to look at whether there is persistence of antigen and whether there are production of pathogenic autoantibodies as drivers of this immune dysregulation. So this work in the lab was led by Chan Phetsiphan with great skill and speed, and the clinical cohorts were put together with equal skill and insight by Gail Matthews and David Darley. Stu Turville and his group have done all the neutralizing antibodies for us, and great thanks to the nurses at St. Vincent's who did all those quality of life assessments. None of this would be possible without the excellent biobanking at the St. Vincent Centre for Applied Medical Research, and we have collaborators at the Garvan and Doherty that have helped us with various assays, as well as Boston University. And this was put together with a range of cobbled together funding from various the university funds, philanthropic funds, and small contributions from the Australian government. Thank you very much.